Week 2, Part 5, Nursing Assessments. Community assessment is an effort to identify and prioritize a community's health needs accomplished by collecting and analyzing data, including input from the community. This is a key part in developing a relationship with your community. First thing, of course, with any nurse process is starting with the assessment. Data collection on health and factors affecting the health. This assessment data may be either quantitative or qualitative. Quantitative data reflects numbers of people, characteristics, or events within the population. Qualitative data focuses on perceptions of health, attitudes, and health concerns as voiced by members of the population. First, we have to obtain the data. This could be done by numbers of ways. Focus groups, informant interviews, residents, secondary analysis of existing data, and then data from Geographic Information Systems, or GIS. Assessment mapping is a process that identifies the geographic features of the environment that influence the population health. Now would be a good time to download or print out the data collection table. This will help you break down the different types of assessment gathering. We start with the informant interview. There are key informants, both formal and informal leaders. The strengths are minimal costs, participants serving as future supporters, and then the limitations are building in bias, and of course then finding a time and a place. A community forum is that of an open public meeting. Its strengths are opportunity for community input, and it doesn't cost much. However, the limitations is that it might be difficult to find a time and a place. There could be a drift from the issue. Also, there will be less possibility that a less vocal person may be reluctant to speak due to the size of the forum. Data compilation is using the secondary data sources. These are the statistics that are collected: birth, death stats, census data, morbidity and mortality rates, to assess problems. This is data that is already collected in many needs assessments. The strengths is already created. The limitations is that it may not represent the current situation. For instance, the official census data is coming from 2010, and we are 6 years into this decade. Windshield survey or shoe leather survey is a descriptive approach to assess several community components by driving or walking through a community. This asset mapping is a process that identifies the geographic locations of the features of the environment that influence population health, such as a location to a healthcare institution. Windshield survey is an informal means of collecting population assessment data by driving through the area and observing its visible features. This is something that you will be doing for your project. Another way to do it is the shoe leather survey. The only difference is you're walking versus driving. Strengths, it gives you a descriptive overview of the community. Limitations, and a key part is it is subjective. It's subjective to your observations. Normally, the subjective isn't worried about when doing an assessment of a patient, but in this case, being too subjective can cause somebody to sway one way or another. Another thing, which is a huge safety thing, is you need a driver so you can take notes about the community elements. You should not be driving and taking notes at the same time. Always have a partner, and in groups, and if you choose to do your project in a group, make sure that one person drives and the other people take the notes. The other part is depending upon how big of an area you have to survey, it could be time consuming. Focus groups are a smaller sample of a community forum. Strengths are, again, minimal costs, possible participants being potential supporters, which is key, and gives you an insight to a community support. However, it can be time consuming. We also can move off task and have possible discussions of irrelevant issues. And then it's not a representative of the larger population group. It's just the small group's opinions. Surveys. These are specific questions asked in a written format. Strengths are that the data is collected on client populations and problems, and it's just a random sampling. The limitations are usually a low response rate, expensive, time-consuming, and possibility of collecting just superficial data. Observations are very key. Participant observations are that of formal and informal community activities. You learn a lot, as you probably have done many times, learning things about people just by sitting and watching them. The strengths are they do have an indication of community priorities and the environmental profile. They also help you identify power structures. The limitations, again, are that biased. What is your bias in what you're seeing? Are you just seeing something that you think you know about, or do you know for sure what is going on? The next step after assessing, of course, is planning. These should be strength-based rather than deficit-based, collaborative and systematic process to attain the predetermined goal. When we focus on deficit-focused planning, the population is perceived as unable to resolve its own problems or as a problem to be solved. So then we move again away from where we're going and trying to get community empowerment. So we always want to focus on strength-based rather than deficit-based. The levels of planning start with specific health-related programs and then development of those community-level interventions. The program planning process may incorporate a variety of steps depending upon the planning model used, and we've gone over the different health plan models before. This might be prioritizing the population health issues, the severity of the threat to the population health concern, the degree of the concern, and the extent to which meeting one need depends upon meeting other needs. When we create the planning group, we want to identify objectives. We want outcome objectives that reflect the expected level of performance of the program for its intended beneficiaries and the overall population. Process objectives are statements of the level of expected performance program staff in carrying out a program. Criteria for effective program objectives are making sure that they're measurable, precise, time-specific, reasonable or practical within a group capability, legal, congruent with population social norms and values, carry minimal side effects, and fit the budgetary limitations. The resources are that of personnel, money, materials, and time. So then, once we've implemented and have started to intervene to help the community, we then have to evaluate, as with any nursing process. Here we evaluate the plan itself and then plan for the program evaluation. The goal of implementation is to integrate program activities into existing networks in such a way that the program is sustained as long as the need for it continues, and that you can replicate it into another community. Acceptance by community policymakers convince those that are able to carry out the plan to implement as it is designed. Acceptance and participation in the plan program by members of target populations. Potential resistors will always be aware. They can make or break a program. Strategies for implementations have three basic tasks: an activity delineating and sequencing, task allocation, and task performance. These are reasons for evaluating a particular program. We want to justify why we're continuing it or whether we need to expand it, improve what that quality is provided, determine what future actions are, determining the impact, make sure people are aware of the program, assess the personnel involved that are into the program, what their performance is, assess the political expectations, I believe is what that needs to say. Also, in the process, we need to consider what the programs are, what the expenditures are, demonstrate the achievement in the program. Should the evaluators be people who implement the program? Maybe they should be program beneficiaries or outside experts. Who's going to have the credibility in evaluating the program? There are always political considerations. There might be a delay in decisions about the program, a discontinuation of the program, policymakers that may also choose to evaluate a program in order to escape pressure from competing interest groups, providing legitimacy for prior decisions to support a program expansion. A good example of this is LB 18, working on the mandating of the meningitis vaccines. Again, we have to consider the ethical considerations. Next is the type of evaluation. It may occur either prospectively or retrospectively. If it's prospective, it's a planned and criteria determined prior to the program is implemented. This is usually the recommended approach. If it's a retrospective, it's designed after the program is completed or at least in the process of being implemented. We want to make sure it The process evaluation examines performance, takes a measure of quality assurance and improvement, addresses questions of what is working or not working within the program and why, and any other additional considerations. The outcome then and the focus is on the program consequences. What documents of the program's effect justify decisions to continue, modify, or eliminate it, as with any implementation of a nursing intervention. This may focus on short-term, intermediate, or long-term outcomes. The evaluation process continues to engage the stakeholders, describes the program, focuses the evaluation, gathers the evidence, drawing and justifying the conclusions, and then disseminating and using the findings. And this is a continual process. From this process, then we make the revisions or not, or end the program altogether. The target is always the population as a whole and not just one independent individual. Every problem we face in our society, war, famine, poverty, crime, natural disasters, global warming, affects our health and society. All of these roads lead to nursing.